Welcome to Public Health Matters, where we talk about matters in public health. I'm Jane Goodman, Public Health Network Strategist with the Division of Public Health and Community Services. And I'm pleased to welcome our guest, Lindsey Bond. Welcome, Lindsey.
Hi, Jane.
Lindsey is an epidemiologist with us at the division, and you came on in December, right?
Yes.
Do I have that right?
Yes.
So we gave you a few months, and now it's time for TV. So welcome, and we're thrilled you're here because we have a lot to talk about, because epidemiology has apparently been in the news these days. So we wanted you to come on and help us understand that a little bit better, and things that we can look at. So just tell us a little bit about yourself, where you were before you landed this fabulous position in Nashua.
So I got my bachelor's degree in biology. Did not think I wanted to be an epidemiologist, didn't even know the term existed.
Oh, you should have seen our show.
I ended up working at the medical examiner's office where I met an epidemiologist there and decided that's what I wanted to do. So I went back to school, got my master's, and now I'm going for my doctorate too.
Wow. Do you have a focus, an area of interest, or?
Mostly harm reduction, so people who struggle with substance use disorder and how we can prevent overdose deaths in the state of New Hampshire.
Oh, good. Well, we definitely can use some help studying the data here. As you know, that has been a huge problem. It has continued to be a problem in the city, in Greater Nashua, in the state, even despite the pandemic. And now we're seeing numbers go up again, actually,
Yes.
in that area of overdose and even deaths. So I'm glad you'll be helping us with that data as well. Even though it's part of your studies,
Yes.
I think we will also benefit from that. So that's exciting for us. So my first question before we talk about the dreaded COVID is that I want to define epidemiology, and I have a little definition that they'll put up for us. Because people, you hear epidemiologist, and we were talking a little bit before the show, and we're saying people usually think you're a dermatologist. There's a lot of ologists out there. So what is epidemiology?
So epidemiology is the branch of public health that studies the incidence distribution and possible control of disease. Epidemiologists use knowledge of medicine, different kinds of diseases, and advanced statistical analysis to evaluate exposure or behaviors that could lead to certain health outcomes.
So why do we need an epidemiologist at public health?
Because there is so much data to work with in public health, and data is what helps us determine what needs to be improved upon in public health.
So let's come up with some kind of example, like if there's, and we're not going to talk about COVID just yet, but if there's some kind of outbreak or some kind of, let's just say the flu, but that's not reportable. I know too much. Avian flu, or we were talking about that.
How about we could do overdoses.
Oh, let's talk about overdoses. So what is your role in pulling that data and explaining that to the public and that kind of thing?
So first off, we go by EMS records. So when ambulance arrive on scene.
So that's emergency medical services.
Yes.
Just for our audience here.
And then also if someone arrives at the emergency room in a hospital, that's also recorded. And then unfortunately, if someone dies from a fatal overdose, that is also recorded through death certificates.
Okay.
All that information can be used to try and find some possible trends and who is at risk the most, whether it's just obviously people who use substances in general, but then are there certain populations that may not be getting the treatment that they need? Maybe they don't have access to Narcan. How can we help people with the data presented?
Okay, so you might see that people were not offered Narcan in a certain area. And I think that's one thing that people don't realize about some of that public health data, because it's really cool. And I'm a bit of a data nerd myself, even though I'm not an epidemiologist. I should play one on TV. No, the whole idea that you can look at things by zip code or race and ethnicity or sex, or that gives us so much insight into what we're doing. So specifically, I'm just going to drill back to Nashua because We have a lot of neighborhoods, so where are these overdoses happening? Are there
Yes.
clusters? How can we get to the bottom of this? Where do we need to do more outreach? Where do we need more prevention? You mentioned harm reduction, so maybe we could explain what that is to our...
Yes, so harm reduction is kind of an overarching theme of prevention of certain types of diseases that can happen co-occurring with substance use, so hepatitis C, HIV, AIDS, so providing clean needles is often
it's a way to reduce the likelihood of subsequent
a strategy.
disease.
That's the word I was looking for. And then also providing Narcan to prevent or reverse opioid overdose. So just a few little things like that can actually make a big difference in the community.
And we came to that conclusion because we looked at the data.
Yes.
Because we realized that if people are reusing needles, for example, it can be extremely dangerous. It can, like you said, create even different issues.
Yes.
So, for example, if you are in a situation where you are using drugs and that needle is not disposed of properly or reused, and maybe you have HIV, and then somebody picks up that needle and then they end up with HIV. So we're creating more of a problem. But because of public health data, I'm really pitching it for you here, Lindsey, but because of that public health data, we're able to really understand what needs to be done or how to design interventions. So we really need our epidemiologist on staff in public health. It's a very important role for us. We use your services, so to speak, for so many different things, so many different surveys, program evaluation, because even if we have a program, we want to make sure that it's viable and that it's doing what we thought it was supposed to do. So I kind of gave away some of your questions already. So just tell me a little bit what some of your priorities are right now at public health so people understand. And some of your responsibilities.
So some of my priorities, especially starting as a new person at the division, is to understand where we're getting our data, how valid the data is, and are there gaps in data. So validity is understanding the disease and the certain issues that surround it, and how is this data being collected, and is it being collected in a way that's accurate? And then gaps in data could be, well, we have a population that is struggling with a certain disease, but there's something missing here. Is it maybe, I'm trying to think of an example, but maybe a certain type of risk factor, and are we collecting data where that could be evaluated and considered an indicator for disease?
Right. And you might be looking for the data that already exists out there too. So what are some of your favorite data sources? I guess it depends on the issue.
It absolutely does. I wasn't really very interested in infectious disease data, but since COVID happened,
it made us all interested.
It made us all interested, but then it also made me interested in other infectious diseases. So even avian flu has kind of been making its way through New Hampshire. So that's been really interesting to kind of watch and see where it's going and get that live update as to.
So we don't want to scare anyone. Avian flu right now is in birds.
Yes.
So we're watching it because we want to make sure it's not going to jump to humans.
Yes.
Just as SARS-CoV-2 jumped from something to humans.
Yes. So with the avian flu, it started with wild birds, and it has affected some livestock in the area, but nothing of major concern right now for humans.
And we also work hand in hand. We'll give a little shout out to our environmental health department, who also tracks things like this too, especially things in the environment that could affect, the overall health of the community. There's so much going on all the time. There seems to be something every day. What about, for example, you get these alerts for what do they call it? Can't even think of it, like lettuce, romaine lettuce. That was a big one. So, and I was very upset about the romaine lettuce because I love romaine lettuce, but it was recalled for several months, a couple years ago. So what's the role of epi in that, and how do you figure out like where it's coming from and all of that? And I might have asked a really hard question, but you know.
So it's surveillance, it's tracking data, it's in live time, making sure that you're communicating with other epidemiologists too, because often an epidemiologist focuses on one specific area, so it might be environmental health or food safety, and they decide, okay, there's X amount of people getting sick from a possible source, we need to communicate that, we need to start tracking it. And that way, hopefully, we can mitigate future infections and also probably take away any source of infection as well.
So that gets into investigation, which we're all very familiar with. But so if, say we have the romaine lettuce here in Nashua, I like making up stories, and so we're having the romaine lettuce here in Nashua, we find a source. I mean, would it be something that you'd go out and interview, or would we have one of our community health nurses do that, or is that something that we're charged with?
Yes.
Yeah.
So we do that. It really depends on the situation as well. So say you have one person that gets sick, we'll probably get some information about their symptoms they were experiencing, the timeline of when they ate, when they got sick. And the public health nurse that's in charge of infectious disease investigation will most likely contact that person and ask those questions. And then we may take it a step further and look at the facility, maybe where the food was being distributed, and also follow up with possible other customers that may have consumed that food.
Right. So it's, you know, we try to jump on that very quickly.
Yes.
When stuff like this happens and we get alerted, I mean, how does the state get involved, or is it really local here?
I think it's very dependent on the severity of the disease and also how many people are being infected. Because when you have something like E. coli, you have maybe 1 or 2 cases in Nashua. That's not a huge concern. It still needs to be reported to the state. But when it becomes a much larger outbreak with a more severe disease, then the state would most likely get involved as well.
Okay. So there's all different levels of involvement.
Yes.
And so you had mentioned the word surveillance, which is a really loaded word because it can mean a lot of different things to people. So I'm going to clarify what it does not mean in epidemiology. I mean, I do think of epidemiologists as detectives. I really do, because you are looking for clues, you're looking for sources, you're looking, like you said, you use your medical knowledge as well to try to determine things. You might come up with programming even, like you said, to mitigate certain outcomes. But surveillance is not spying. It's not, you know, so it's not Sherlock Holmes looking at, you know, what you ate for dinner and how you ate it and with who and in the candlestick, with the candlestick in the bedroom. It's very different. It's really like that population.
Yes.
So I'm going to let you take it from here. I don't want to steal your thunder.
It's kind of, it's watching and collecting data in real time. So when things do happen, we're already there investigating. It also helps us plan if there are any serious diseases that may appear, like COVID-19.
There, you said it.
Because, you know, it started over in another country. Epidemiologists over in the US were already very much aware that it was happening, and were ready and preparing for this to come to the US. And that's a lot of what surveillance is that prep.
Yeah. And it seems like surveillance also gives you a baseline, right?
Yes.
So it's like we know what say the status quo is. That's our surveillance, and we're always doing surveillance for, you know, gosh, how many diseases there? If you look at the infectious disease thing from the state of New Hampshire and what's reportable, I mean, the list, I have the poster in my office, but it's a huge list of things that, you know, could come up. So.
Right, and you had mentioned the baseline. That can also help us understand if there's any arising issues that may be causing more infection. So say we have a baseline and then 6 months later we have this huge increase in cases for whatever disease, that's something we probably need to look into.
Yeah, and so there's some kind of trigger points.
Yes.
How do you get alerted from that? Is that like, are there certain things that you definitely follow each month, or do we just rely a little bit on our public health nurse who is hearing from the state?
Yes.
I mean, you know.
It's a little bit of everything. I try and check data regularly for infectious diseases. And then also just staying on top of different guidelines around infectious diseases like COVID. But then there's also that piece where we have a public health nurse that tracks infections in schools like the flu and COVID. So there's multiple layers to the surveillance piece.
Yeah. So was there any trepidation coming from, you were in Massachusetts working in a very different environment around substance misuse. But was there any trepidation coming in and knowing that you were going to go feet first into COVID? Because, for us who've been working in it, I've been doing it it's going on 2 years, and the changes and keeping up with the changes it's really complicated. And I think that's part of our issue.
Yes.
When we message this stuff, and from a national level, state level, all on down, it's very complicated to message because it's changing so rapidly.
Yes, and I was a little nervous about getting into the throes of COVID, but the time that was spent not working on COVID, I still paid attention enough to know, okay, what would I want to do if I was in that position? Was there anything I would want to change as far as messaging? How can I clearly and concisely communicate to people who do not have a science background? I think is extremely important.
And we've asked you to do that
Yes.
already, probably within the first 2 weeks that you were here. I know we said, can you write an article about this? Because there's so many new therapies coming out,
Yes.
for example. And then you wrote one about wastewater treatment, which, is another interesting way to do surveillance for COVID, and probably a bunch of other things. But right now we're still focusing a lot on COVID becoming endemic versus a pandemic. So let's just talk about some major projects that you're working on, or major initiatives for now, and there'll be more, we always know. Every time we turn around, there's something new. And actually, you and I have been working on this one with the Kresge Foundation around health equity, which has been a really interesting project, and we're at the midway point. So just tell us a little bit about the project so people know what we're doing over at Public Health.
So I started about halfway through the project. The project focuses on interviewing community members on how their feelings or experiences are with mistrust in the medical field, or with doctors, providers, and even people who work in hospitals that may be doing like front desk work or admissions, how their experiences are with that based on their kind of cultural background, but also, we had a new African group, which was immigrant African people, and how that experience is so different from, say, your African Americans who have been here long enough, they're not immigrants, but very different experiences.
Right. So I'm going to back up because it is a study on the BIPOC population, which is Black, Indigenous, people of color. And so we did start the study around, these listening sessions. We did, like you said, New American group that were primarily African.
Yes.
And then we did have a group, I'm trying to remember them all now. We did have a Portuguese-speaking
Yes, and a
group,
Spanish-speaking group.
and a Spanish-speaking group. And then we did have the, African-American group, the American African-American group. So there are 4 groups and very different results, and a lot of similarities too. Trying to understand if they trusted the medical profession, how could we, what could be done so that they would trust the medical profession. And now we have the second part of the survey, or the study, so to speak. And that is, I'll let you do that.
Yes, so after the listening sessions were done with the first group, our community members, I did qualitative analysis on those interviews, which is pulling in all the words from the interviews and counting how many times certain phrases or words were mentioned, because that way we can start to find common themes, or in this case concerns, with the community members, and then pose questions to individuals that work in hospitals, like providers and even, management, CEOs to that level. So the next step now that we have our common themes, is to interview. We made our questions, and we're going to go out and hopefully get some good feedback, and hopefully, also get some providers thinking about how their patients experience care too.
So it creates awareness
Yes.
too, and then we can use what we learn, again, to design the interventions, to talk about how do we communicate what we learned, both from the patients and from the providers or the office staff or whomever it is, on how to bridge that gap so that there is more trust, and what are the key elements that are missing right now.
Yes.
So it's an exciting time. And like you said, we're midway, so stay tuned. We'll have you come back on for that. You're also doing a project with our behavioral health strategist and specialist, looking back on the last 10 years on substance misuse and a lot of preventive efforts. So
Yes.
what are you guys doing for that?
So as of right now, we're doing a survey to examine community members' experience with different events and programs that were offered over the last 10 years that kind of segued into substance use prevention, but also kind of mental behavioral health. So programs like suicide prevention, language training around substance use, making language person-centered, so we're not creating more stigma by calling people certain names.
Yes.
Very important. And also just kind of bringing community members together. I know Lisa, our behavioral health specialist, did knitting at one of the recovery houses. So just different programs to get all types of community members involved and hopefully create bonds so that there's less risk of substance use and mental health complications or issues.
And this has been a 10-year initiative.
Yes.
So this was kind of the capstone of like, we've been doing this for a long time. Have we been effective?
Yes.
And that's also a nod to our funders, because this is such a critical problem in our community that we really have to address, and we have to keep addressing. And a lot of the efforts have been on prevention and prevention in the schools, because we want to reach the kids as young as possible so that they understand, the danger of all the drugs that are out there. And then one thing I know that you do is evaluation of our programs. You've become quite the survey queen lately, Lindsey, so we thank you for that, because that is a lot of work, a lot of different surveys every time. And I think people need to realize that. So, we're not just shooting blank when we're doing public health initiatives. We may have an idea brought on by a survey. Once we implement that idea, we want to check back to see if we had any effect.
Absolutely.
And we just call that evidence-based. We want to make sure we have evidence that what we're doing is working. And that's so important, because you don't want to keep spending money on things that aren't working.
Right, and it also gives us an idea, like, do we have strengths? Do we have weaknesses? Is there things we could change or that we could continue a certain program to really get community members to get the most out of what we're offering?
Right. And a lot of times when we're surveying, we are going right to our community members,
Yes.
the people that we are touching with these programs, the people that are in need of the programs. So it's not just us sitting around a table saying, oh, let's ask this. We go out to the community members. What are your comments? What are your concerns? Just like you explained with the Kresge Foundation, so that we get a base of what the concerns are, and then we bring those to the providers, and then ultimately, hopefully design something to bridge that gap. So I guess we're at the point where we can talk about COVID. I was really trying to avoid it to keep friends in my studio here. But right now, we are looking at COVID very differently.
Yes.
And the state dashboard has been down. So we're not going to give specific numbers today, but I think it behooves us to at least explain this whole thing called community levels and what they are. And they'll get put up on the screen. But right now, we have the CDC has given us a new way to look at this. And again, I say new because we're learning. We're learning to fly the plane, build the plane while you fly it or something, whatever that is. We're still doing that with infectious disease. And this one's been sticking around for a while. So tell us a little bit about the community levels so they can understand a little bit better.
So community levels is a way to measure severity of disease because COVID-19 is becoming endemic. Transmission is still going to be
Yeah.
continuous. So how can we measure, how can we measure the severity best and make good decisions around it? So for right now, what the CDC is doing is community levels, which measures the 7-day total of new COVID-19 hospital admissions per 100,000 population, and the 7-day average of the percent of inpatient beds occupied by COVID-19 patients.
Okay.
So hospitalizations in general are very low right now. And that's why in Hillsborough County, we are considered at the community level as low, but also for the whole state, we're actually considered low.
Yeah, and I have another map of the United States, but you can see when we put that up there that New Hampshire is green, 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 as is most of the United States right now. Little tip in Maine, and I'm so bad with my western states, but whatever's north of Idaho, I know Idaho, has a little bit of yellow in there, medium, very little bit of red, a little bit in New York State, but very small pockets of it. So what are ways, if you want to just quickly describe like the whole wastewater surveillance?
Sure. So wastewater surveillance has been around for actually a very long time. It's been used, I can't remember, but even to surveil like substance use, certain drugs that can be detected in the water. Yeah, so it's been around for a long time. It's just COVID-19. It took a little bit to set up those relationships with the wastewater plants. And basically what happens is they collect samples from the water. They usually submit it to a state laboratory, and they will do analysis and detect how much virus is in the water. It's difficult to estimate how that's actually representing the whole community, especially when you have wastewater plants all over the place.
Right. But we do have one close.
Yes.
And we do have one in Merrimack, so
Yes.
it's not Nashua, but it's close. And, we remind people that we serve the greater Nashua region, and people come in for services into Nashua, so it is at least some information
Yes.
that we have.
So, and it's good it allows us to detect in what trends are we going. So are we having a higher virus detection, lower virus detection? It's great in that way. We can kind of see where we're going. It's actually also one of the most accurate because everyone uses the bathroom.
Yes, yes, they do. We hope. So,
yeah.
so that's great, and I hope that the city moves towards that. Hint, hint. And because that would be great. To be able to do that surveillance here as well. So thank you, Lindsey, for coming on the show. I do really appreciate you stepping in and teaching us today. And I want to remind our audience to get fully vaccinated if you have not already. Protect yourself and those you love. First series, first shot, second shot, it's all good. Boosters, please, please, please. That's our best defense against this virus right now. And studies have shown over and over that there's much less severe illness and hospitalization among those who are vaccinated. So please take those steps if you have not already. And I want to remind folks that we have our health clinic. We have openings on Tuesdays, Wednesdays, Thursdays, and Fridays. And Thursdays specifically reserved for STD, HIV, and HCV testing. And Fridays, Tuesdays, Wednesdays, and Fridays, we do lead testing. And immunizations can be had any of those days that we are open. If you want an appointment, 589-4500, press option 2. And that's all we have for you today. So have a wonderful, wonderful week ahead.